traumatic refractory ocular hypertension.
Good evening, all. I would like to thank APOS for giving me this platform to talk about traumatic ocular hypertension and glaucoma. I am not getting the slides here. As we all know, ocular trauma is a frequent cause of blindness, in particular with the development of glaucoma across the world. So, ocular trauma refers to a heterogeneous group of ocular disorder. Secondary glaucoma refers to a heterogeneous group of ocular disorder with the high risk of IOP rise, that is ocular hypertension, ultimately ending with glaucoma, with underlying variable different multiple mechanisms for the cause. So it's more common in young active males, in particular in the workplace or any sports injury related. In particular, country like India, we have cracker injuries. So the risk of traumatic glaucoma post open globe, it is around 2.67, and post closed globe, it's more than open globe injury. It can occur either soon after injury or even years later. So these are all the types of ocular trauma which can lead to IOP rise. Commonly, we encounter post mechanical injury, chemical injury. Other injuries like thermal, electric shock, and radiation injuries also can lead to secondary glaucoma. Mechanical injury, when we come to this, we either closed globe or open globe. Of course, surgical trauma also can lead to IOP rise, in particular post cataract surgery, penetrating keratoplasty, Vias procedures, buccal procedure. So, what are the causes? We can enlist the causes during early phase as well as the late onset. Early, as we all know, the inflammation is a major cause. Any tears in the trabecular meshwork, hyphema, can lead to early phase IOP rise. Late onset, development of peripheral anti-synechiae, hyperpigmentation in the angles, angle decision, and lens-related factors. Either change in the position of the lens or lens cataract, traumatic cataract with anterior subluxation. In case of open globe, retained foreign body, and Schwartz syndrome, it's RD-induced pigment release causing secondary glaucoma, open angle glaucoma. And late phase, again, one of the most important factors which can lead to glaucoma, and mostly it is missed out, is epithelial or fibrous ingrowth. So chemical injury most commonly encountered in alkali injury. So as we all classify any glaucoma, either primary or secondary, it's open and angle closure, open angle and angle closure. When coming to the closed angle, either it is anterior pull or posterior push due to lens induced, that is iris lens diaphragm push forward. Pull actually due to the development of anterior synechiae. Open angle, either it is pre-trabecular, trabecular, or post-trabecular. It occurs basically due to aqueous outflow obstruction by the hyphema or ghost cell. Post-trabecular, it can be due to rise in episcleral venous pressure, post-carotid fistula. So the mechanism of closed globe injury, we all know there is any concussion injury, concussive injury, there is anteroposterior compression with equatorial expansion with pushing of the intraocular contents posteriorly, again rebound factor. So which can lead to aqueous forcibly displaced laterally and backwards with limbal stretching together. It can result in 7 ocular rings rupture that was coined by Campbell. It could be either pupillary sphincter tear, irododialysis, angle decision, cyclodialysis, trabecular tear, zonular dialysis, and the last is retinal dialysis. So what are the predictor which when we see any traumatic glaucoma, we should keep in mind the following factors. Nowadays, we are addressing them as biomarkers. Predictors for chronic traumatic glaucoma or ocular hypertension. First and foremost, hyphema, which occurs during early phase. Angle decision more than 180 degree. And the high baseline intraocular pressure. And lens related, if there is any traumatic cataract or lens displacement. And increased angle pigmentation or any iris injuries like sphincter tear. So workup, we should have a detailed history elicitation, including the mode of injury, the direction of the force, time since injury, extent of the vision loss, any treatment was taken earlier, prior ocular complaints present before injury, any family history of glaucoma, and followed by careful comprehensive evaluation, intraocular pressure examination, gonioscopy. Gonioscopy should be avoided when there is hyphema, risk of rebleed. Fundus examination. In the posterior segment is hazy, we should go for B scan. and UBM can be done in particular cases. So management based on the on my left, these are key points present in the management. Flowchart has been given. If there is a secondary glaucoma due to ocular trauma, you have to make out the cause for it. If you find the cause, you have to address it medically. And if IOP is controlled, then you look for any optic disc damage. If optic disc damage is not there, consider tapering medical therapy and look for presence of angle recession. In case if there is any angle recession and when there is no IOP rise, when the patient presents to you, the patient requires lifelong follow, because the angle recession induced glaucoma can occur any time between 3 years to 10 years. So on my right, that algorithm says traumatic glaucoma after closed globe injury. Early days and intermediate IOP has to be checked, and if it is the cutoff is less than 28, you have to go for topical and systemic glaucoma medication based on the patient's comorbidities and any other contraindications. And if it is more than 28 millimeters of mercury, you have to go for maximal medical therapy and maximally tolerable medical therapy, which includes parenteral and oral hyperosmotic agents and carbonic anhydrase inhibitors. In case of even with this, the IOP is going to remain high, that's more than 26, we have to go for alternate procedures, surgical interventions like trabeculectomy. If you can't touch the eye, if the IOP still remains, you have to go for a preliminary procedure called diode laser photocoagulation. And if the pressure is under control, we can gradually taper the drugs, but we have to keep in mind the IOP and the angle status and the posterior segment for the optic disc changes. If it occurs late years, then glaucoma medications and surgical intervention based on optic neuropathy. Because when we say glaucoma, then there should be optic disc changes, and if the patient can do fields, you have to document the fields, and it has to be repeated. So here I would like to present a challenging case. In this regard, I presented this briefly about the traumatic glaucoma. So we saw a 45 years old active male. When he was away from the sports activity, somebody was playing, so he sustained a ball injury. His IOP became very refractory. We maximally tolerable medical therapy, and we couldn't post him for filtering surgery. So as a prerequisite to do pre-filtering surgery, we posted him for continuous wave transcranial cyclophotocoagulation, that is in staged, that is sequential and titrated. So instead of doing for inferior 180 degree, we did for 1/3, that is 4 clock hours we did. Then after 1 week, we rechecked again, the IOP was not satisfactory or not acceptable to touch for the filtering surgery. So we went ahead with the next stage, that is again 1/3, 3 new quadrants and one clock hour overlapping the previous DLCP site. To our surprise, but we expected with our previous clinical experience, with this two-staged DLCP procedure, his IOP came down to less than 30, and we could post him for trabeculectomy with mitomycin augmentation and releasable sutures. Touchwood, till his last visit, his IOP came down to 14, that is the complete success. It's not a qualified success without any anti-glaucoma medication. So take home would be, any trauma-induced IOP, it has multiple mechanisms, so we need to address so many factors. When we do gonioscopy, increased pigmentation, angle recession, and any sphincter tear, that also indirectly gives a clue that the patient may develop glaucoma later on. So it's very crucial to identify the underlying cause. Visual outcome can be good if we control the IOP and timely management. This continuous wave here, I would like to highlight the continuous wave transcranial photocoagulation can be extended to patients even with good vision. It can be an excellent tool for a refractory glaucoma. It has favorable relatively safety profile. Thank you so much. Thanks.